Welcome to MD Newsline, Dr. Kaiser. Thank you so much for taking the time to join us. Can you please introduce yourself to our audience?
Sure. Yeah, I'm Martin Kaiser. I'm a consultant hemato-oncologist at the Royal Marsden Hospital in London, and I'm also a professor of hematology at the Institute of Cancer Research, also in London.
Mm. So you gave a presentation here at EHA. Can you tell me a little bit about what you discussed and what the focus of your work has been?
Sure. Yeah, my focus is actually a bone marrow cancer called multiple myeloma. It's a relatively uncommon cancer, but actually it's common enough for most people to know someone, with the disease. Multiple myeloma is quite an aggressive, or can be quite an aggressive cancer, but it is very different from person to person. It's a disease that we found over the years can have very different levels of aggressiveness, and I have focused on high-risk myeloma, so the most aggressive form of this disease, because naturally it causes the biggest unmet need and the biggest problem for patients and physicians alike.
Mm. So what makes a myeloma fall into the category of being high risk?
So it has been for a long time actually very difficult to discriminate or to really diagnose patients with high-risk myeloma correctly, because you need really advanced genetic tools to identify it correctly, and only recently have the diagnostic tools really been shaping up so that we can use them more in a day-to-day practice. An important step forward is that very recently, during this meeting, actually, a new guideline has been published about using more advanced genetic tools to identify high-risk myeloma. But there is still even more improvement where we see new data coming out, and that's actually part of what I've been speaking about at this conference, how we can diagnose high-risk myeloma better, but also how we can treat it better, because we now have evidence that we can improve the lives of patients with high-risk myeloma.
Yeah. So tell me a little bit about kind of give me the main beats of your presentation.
So I was really focusing on how we can optimally manage patients with high-risk myeloma. I've already mentioned that diagnosis is a big part of it. And this is something that is, of course, often happening not directly in the doctor's practice. This is actually something where we have to get our tools in the laboratories properly lined up so that a patient gets the full amount of information to make the right decisions. Ideally, it should be a joint decision-making process between the doctor and the patient to understand that we have a different type of disease than most other patients with myeloma, and that different type of disease requires a different type of treatment. The start of treatment, actually, for most patients we have found is now very, very good. So we don't necessarily need to start modifying the treatment for high-risk myeloma patients early. The very first 5 to 6 months of treatment are actually pretty similar for our patients. But what we've learned over time is that high-risk myeloma, many types of myeloma respond to the treatment initially, but the high-risk myeloma patients unfortunately see the disease coming back quite quickly. And that's actually what we've now got a much better handle on through a prospective trial called the OPTIMUM trial that we have run, but there are also other trials that have shown very similar data, like the CONCEPT trial that was run by another group, that really show that the patients stay in a much better, longer remission if we use our drugs better that we have available for this disease. So the trick is that we don't drop the intensity of the treatment after 6 months, but we actually keep it up going. Of course, we need to balance the side effects for the patients as well. But we now have found out, I think, the right balance. Most patients can continue with the treatment for a long time. And we have shown that there is nearly a trebling of the progression-free survival. So patients staying in a remission for nearly 3 times longer than in a comparative group. And we're close to doubling the survival time, actually, of the patient.